deliver a talk on this rather difficult topic. This is not my research work. The relevant citations are at the footnotes of the slide or in the main slide. I have no conflict of interest to declare. So, phobic vertigo from 19th to 21st century, from psychogenic dizziness to the functional symptoms. 3 publications in German language appeared around 150 years back, 1870, 71, and 72. They described vertigo in plaza, fear of marketplace, and fear in plaza. These 3 important publications described almost everything which we know about phobic vertigo in its various forms to be discussed in this slide. For next 100 years, the term psychogenic dizziness was used in a very loose fashion, rather not loose exactly. It was a time when the psychogenic dizziness was used once the organic causes of the dizziness was ruled out. But this was a false dichotomy. This we will discuss in one slide. For the decade 1975 to 1985, supermarket syndrome, space phobia, motorist vestibular disorientation syndrome terms were used. Over the next 20 years, the giants in neurology discussed the entities which were neuropsychiatric, space motion discomfort by Jacob, visual vertigo by Bronston, phobic postural vertigo by Thomas Brandt, chronic subjective dizziness by Stapp from Philadelphia. There were 6 publications in the late 19th century from 1868 to 1895, and they had many things in common. The symptomatology was mainly dizziness, fear of crossing public squares, feeling of anxiety, and vertiginous attacks with disorientation. And this was the time when some of the cities in Europe were undergoing expansion, namely Berlin, Vienna, and Paris. The triggers were crossing at public squares in almost all of these publications, and most of these publications describe this as a anxiety related state or a psychological state, except the one which was considered to be a neuro-ophthalmologic syndrome by Benedict in 1870. So with so much of knowledge available in the 19th century, what happened in the 20th century or most part of the 20th century? From psychogenic dizziness, in 19th century, 3 important syndromes were there. In the top left, you see the vertigo in plaza, and in the top right, you see the fear in the plaza. These were pure neuro-ophthalmological syndrome by Benedict and pure psychiatric syndrome or a psychological syndrome by Codis. While in between, the fear of marketplace, the Westphal described, was a mixed syndrome involving neurological as well as psychiatric or anxiety-related illness. It was also known that habituation by systemic exposure, it leads to elevation of symptoms in each of these 3 syndromes. This was a forerunner for vestibular rehabilitation therapy. And it was also known that autologic triggers in patients with anxious disposition led to these syndromes. So almost everything was available in piecemeals during these 28 years from 1870 to 1898. So what went wrong in the 20th century? In 20th century, we chose the otologists and the psychiatrists to choose the different ways. If you have a organic vestibular illness, either central or peripheral, it cannot be a psychiatric illness and vice versa. And so there was a false dichotomy. Why was this false dichotomy? The B is not equal to A, provided these 3 conditions are fulfilled. All is known about A, all is known about B, there is no overlap, and there is no one other, but there are unknowns. As we had discussed in our previous session, it is not too long, 23 years ago in 1998, superior canal dehiscence syndrome was discovered. In 2012, the vestibular migraine came into existence by the Vestibular Society criteria. So this approach was not a approach, and that was because of the term psychogenic dizziness for a long period of time. So in the 21st century, we see that there is a considerable overlay between the structural cellular otological illnesses along with psychiatric and functional illnesses. For example, Meniere's disease is a structural disorder, vestibular migraine is a cellular disorder, and it has several overlays with psychiatric and functional symptoms. So this is a faulty approach, and this has to be abandoned because it is not a case of ruling out, it is a case of diagnosis of ruling in. So what is phobic vertigo? Phobic vertigo is a chronic functional condition comprising of dizziness and non-spinning vertigo induced by upright posture, self-motion, challenging visual environment. Common triggers are vestibular visual conflict and intense visual environment like cinema halls and supermarkets. Some patients develop functional gait disorder and excessive vigilance about the balance and situation. However, in most patients, the gait is normal to an observer. Recently, it has been lumped by a number of related conditions, including the supermarket syndrome, phobic postural vertigo, space motion discomfort, visual vertigo, and chronic subjective dizziness. So the current scenario is that 4 important syndromes like phobic postural vertigo, space motion discomfort, visual vertigo, and chronic subjective dizziness have been lumped into a barrel called persistent perceptual postural dizziness, like several old wines in a new barrel, but it is being increasingly recognized, as in the previous lecture of the learned colleague from Japan, that each of these syndromes of PPV, SMD, VV, and CSD could be the subtypes of the triple PD. So the criteria, I'm skipping this slide because my learned colleague from Japan had discussed this in his slide. So all 5 criteria have to be fulfilled. Precipitants are patent carpets in the hotel lobbies and busy streets, and if the motion is added, things are made worse. It was recognized as a disorder in 2015. 1 in 4 people who suffer from vestibular disorders such as vestibular neuritis or Meniere's or BPPV may go on to develop triple PD. It can happen concurrently with other vestibular disorders. That is, a vestibular disorders can have a triple PD side by side, and so it's not a diagnosis of exclusion. It is more common in women, particularly in ages 30 and 50, and it is the second most common disorder reported in the dizziness clinics and is especially prevalent in the middle-aged group. The related disorders and previous incarnations have been on the basis of longitudinal course, identification of complex symptoms and clinical syndromes. They may be either episodic or chronic, fluctuating, chronic with fluctuations, and they have been subdivided on the basis of triggering events, primary symptoms, provocative disorder effectors, phobic symptoms in various permutations and combinations. As we had seen, the 4 important syndromes, visual vertigo, phobic postural vertigo, chronic subjective dizziness, and triple PD. The phobic postural vertigo and the triple PD, they are almost the same, except 2 differences, that the fluctuating phobic postural vertigo is replaced with chronic with fluctuations in triple PD, and the minor phobic symptoms which were included in phobic postural vertigo have been removed from the classification of triple PD. So we need to know some physiology. The sensory inputs, which are visual, vestibular, and proprioceptive, they are processed centrally by the brain through cerebellar pathways and the vestibular nuclear complex, and this generates a motor output in the form of eye movements and positional movements. According to one of the 2 theories of the phobic postural vertigo, the space constancy theory, propounded by Professor Thomas Brandt, during normal circumstances, the minor self-generated body sways and involuntary head movements in the upright stance are not perceived as accelerations. The environment appears stationary despite shifts in the retinal images. This space constancy is maintained by concurrence of the voluntary impulse to initiate a movement and delivery of adequate information in parallel to identify this as self-motion, that is called the reference copy. In phobic postural vertigo, it is postulated that either the efference copy is lost or there is a decoupling between the efference copy and the reefference, that is the actual motion. Another theory is balancing at normal and high risk mode. Walking on a slippery wet surface like ice, we have to walk like a penguin. Standing on a ladder gets the body stiff. One takes shorter strides, focuses on staying upright. At this time, the balance system uses less of information from the vestibular system and more from the visual system. Normally, when the risk of falling is over, the balance system goes back to the normal. So this is normally occurring. However, in triple PD, the system stays in high risk mode always. This causes a vicious cycle, worrying about fall, paying more attention to keeping balance. Brain stays on an alert mode with increased dependence on the visual input, and the visual inputs like busy patterns and movement cause worsen the symptoms. How the triple PD patient presents: non-spanning vertigo, unsteadiness, lightheadedness, mild dissociation. Unsteadiness of gait and non-spinning vertigo dominate the clinical picture. Upright posture and motion, active as well as passive, worsen the symptoms. Visual hyperintensities in isolation as a symptom of visual vertigo is a characteristic feature of triple PD, and as per my colleague who delivered a lecture previous to me, has identified that it is one of the most common subtypes of actually with the active motion of the triple PD. So as we had seen in one of the earlier slides, the structural illnesses in patients who are predisposed and with some precipitants which may be vestibular or psychological may lead to merger of structural and psychological ailments leading to functional PPD. But what actually happens is depicted in this slide. Normally, when there is a dizzying trigger, it could be a vestibular crisis, pre-syncope or panic attack, there is acute adaptation, and this involves high-risk postural strategies, and recovery is almost complete or uneventful. However, the high-risk postural strategies sometimes starts a cascade or a vicious cycle. There's increased introspective self-monitoring. There's top-down distortion of the afferent signals, and there's perception of dizziness and unsteadiness, which further increases the high-risk postural strategies. And this is particularly common in patients who have predisposing factors like neurotic personality and pre-existing anxiety disorders. And the three things, upright posture, motion, and visual patterns, they increase the illness. So it has got its adverse effects. The increased introspective self-monitoring leads to neck stiffness, fear of falling, gait disorder, and agoraphobia. And the top-down distortion of afferent signals, which is occurring again and again in a cyclical fashion, results in fatigue and dissociation. To break this cycle, we need readaptation by vestibular habituation exercises, cognitive behavioral therapy, and in some cases medications leading to recovery if instituted early in the time. So physical therapy and psychotherapy for the triple PD basically addresses four issues: stiffened gait and stance, motion sensitivity, visual dependence, avoidance of provocative environmental factors. Vestibular rehabilitation is by normalizing the stance and gait, habituation exercises, and gradual exposure. The cognitive behavioral therapy reduces the excessive body vigilance. Desensitizing strategies are done to complement the physical therapy, countering the fears of dizziness and anticipatory anxiety, and promotion of gradual exposure. The pharmacotherapy includes selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and alternative drugs like mirtazapine. The data is uncontrolled as the randomized studies in the pharmacological treatment are still lacking. The treatment with vestibular rehabilitation involves a wide variety of exercises, which could be adaptation, gaze stabilization, target shooting, habituation, balance retraining, balance exercises with eyes closed, strengthening exercises, grip training, range of motion exercises, learning and predicting strategies, breathing and relaxation strategies, and walking and other aerobic activities. The main are enhancing the gaze stability for the saccades and vestibular ocular reflexes, and for the imagery pursuit with eyes open and eyes closed. Then the truncal stability with the exercises with the toes up and toes down, bringing the center of body backwards and with toes up and forwards with toes down, repeating several times. And an anti-burst gymnasium ball may be useful in some patients. Cognitive behavioral therapy is important. It's a goal-specific psychotherapy. It focuses on the relationship between thoughts, that is cognition and behavior, Cognition consists of core beliefs, that is schemas, conscious and automatic thoughts, some of which are under control, some of which are uncontrolled. The behavior of any individual is the output of his core beliefs, his thoughts, and his feelings. The cognitive behavioral therapy identifies thinking and behavioral patterns that exacerbate the symptoms, changes the way the phobic hypervigilant patient thinks, and this brings about change in his behavior. Gradually exposes to the trigger, increasing over time, so that the trigger no longer causes a panic reaction, that is called desensitization. Reassuring about the benignness of condition, generates fearless conscious thoughts and abolish the fearful automatic thoughts. Goal is to eliminate the anxiety-driven hypervigilance, and this may need many sessions over a period of 6 to 8 weeks. So, summing up triple PD or phobic vertigo, a maladaptive functional syndrome in which patients feel unbalanced despite not falling, feel movement despite being stationary. Vestibular adaptation normally involves bottom-up inputs, which are vestibular and obligor proprioceptive, and top-down attentional control systems. However, sometimes there is anxiety-driven hypervigilance, and this leads to a maladaptive syndrome, which we now define and characterize as triple PD with its various subtypes. Final slide is the first slide was about agoraphobia and the phobic vertigo. Acrophobia and PPV both have something in common. There is susceptibility and there is provoking stimuli. Earlier expenses and heights, the case of acrophobia, and the vestibular disorders and environmental stimuli in the case of phobic postural vertigo. This leads to anxiety to fall off or to fall down, and there is anxious control of postural stability. There's co-contraction of anti-gravity muscles. It has been demonstrated by various stimulometry methods. Inadequate interaction between the open and the closed loop postural control, subjective imbalance, and this further increases the anxiety. So this was my final slide. Thank you very much. Thanks to Professor Thomas Lampert Berlin, Chief Physician at Department of Neurology, for his suggestions and persevering encouragement in pursuing otoneurology.